Very good evening, my dear friends. This is Endocrine Week, which is going on. Started yesterday, and now we're all through this. And yesterday we had a great beginning and went through the great speakers speaking about the recent things. Now, as a part of corporate program, we are today speaking about the early combination therapy of Linagliptin and Metformin. I am Professor Subrahmanyam, KAV, Head of the Department of Endocrinology at King George Hospital, Visakhapatnam. So when we look at the diabetes mellitus, the prevalence is increasing. This is because of increase in the overweight and obese people throughout. There are various reasons which we are going to discuss at a later point of time. This increase in the diabetes mellitus, especially type 2, increases the prevalence of cardiovascular disease and associated comorbidities. And we also know that type 2 diabetes is a multi-organ and multifactorial condition with beta cell dysfunction and insulin resistance in peripheral tissues and the liver. And there is also defective incretin activity, as we are looking at the GLP-1 activity as well as the GLP-1 receptors. And there are elevated levels of free fatty acids because of faulty insulin action to prevent lipolysis at the adipose tissue. And of course, there are a lot of pro-inflammatory mediators which are supposed to increase the cardiovascular disease. And our type 2 diabetes is a progressive disease with deterioration in glycemic control over time and naturally with increase in the metabolic complications. So we need earlier intervention so that you control glucose levels early, probably will control the complications, both micro as well as macrovascular complications. While the control of hyperglycemia remains the paramount and important goal, focusing on the underlying pathophysiology of type 2 diabetes mellitus is important with the aim of potentially providing the disease modification. For example, you are talking about if we have a drug where we can prevent the loss of beta cells, or we can postpone the loss of beta cells and apoptosis of the beta cells, probably patient will have better glucose control for longer period of time, which sometimes that happens in a genetically happy people. So looking at the prevalence of diabetes mellitus, now we have approximately 430 millions of diabetes people around the world. And our Southeast Asian region has the maximum, that is 82 million people. And by 2045, we are expecting 151 million in Southeast Asian region only. Approximately 77% of the people throughout the world are now living in the low and middle income countries like Southeast Asian countries. Of course, we along with China being the top 2 countries holding the number of diabetic patients. So coming to the Asian population, why we Asian population are having more incidence of diabetes mellitus looking at, there is a nutritional transition, sudden explosiveness. So the more and more, for example, you take 30 years back, the food availability itself is very less and the purchasing capacity of the people is very less. So naturally the type of food they could eat is very less. Whereas here now there is a nutrition transition where food is available everywhere and the type of food available also, though we say junk, it contains a lot of fat. And because of this rapid nutrition transition, people are developing overweight and obesity and consequently then diabetes. Of course, the socio-economic development has resulted in so many other things. Apart from the availability of good food, good nutrition, good clothing and good housing, it also made available the mechanic part of the thing, which made the people having reduced physical activity. You start from any persons. For example, a person who is going out for work. Previously, people used to walk to their fields, agricultural fields. Now they are going in a bike to the agricultural field. Previously, we all used to bicycle to the school. Now people are going on an auto or a car or a bike to the school. The same thing also is there. Of course, we Asians have a genetic susceptibility. All these reasons are important so that we all develop diabetes early and more. And coming to our own diet, the preferred diet is refined rice and wheat. And of course, this refined rice and wheat has high glycemic index and glycemic this one, and the glycemic load, that will result in increase in the postprandial hyperglycemia, and we know that the postprandial hyperglycemia is related to the endothelial dysfunction and resulting in cardiovascular diseases. So this is how our Asians, we are at a high risk of getting both type 2 diabetes mellitus and consequently postprandial hyperglycemia and consequently developing cardiovascular disease. And the pathogenesis, you all know this woman is octet. And here we can concentrate on two things, most important being that we are also looking at the insulin production from the islet cells. Also, we are looking at the glucagon secretion is increased. Of course, our liver is having insulin resistance, and the peripheral tissue also insulin resistance with reduced glucose uptake. And of course, kidney is also incriminated now with increase in the glucose absorption. And of course, our incretin effect, and this is most important nowadays, the gut and the kidney are being now involved along with the brain in our management of hyperglycemia. So coming to our drugs, the therapeutic objective is threefold. One is we have to increase the insulin production from the beta cells. Or if we cannot do it, then give insulin from outside and simply exogenous insulin is there. And the other one is because there is insulin resistance, because of various factors we discussed, improve insulin sensitivity in the peripheral tissues. Then the liver is the metabolic house of the body, then increase the insulin sensitivity of the liver also. And these are the various objectives of any drugs being given, apart from reduction in the absorption of glucose from the gut and also increasing insulin, glucose excretion from the kidney. These are the various things which we are talking about. And coming to the management of type 2 diabetes mellitus, this algorithm most of us are looking at, and this is those patients with established atherosclerotic CVD or CKD. Here we have separate drugs, and we are not going to discuss them now. But we are talking about treatment of a person with early disease, that's a newly detected type 2 diabetes mellitus, where the atherosclerotic vascular disease or CKD are not there. We are going to prevent them. Then we have after metformin. See, metformin is a first line of drug. We all know it from the last 30 years. And when the patient is having the more chances of having hypoglycemia, then probably the DP4 inhibitors, the GLP-1 receptor agonists, SGLT inhibitors, and thiazolidine are the drugs which will prevent or minimize the hypoglycemia risk. Whereas the patient has uncontrolled hemoglobin A1C with these drugs and the other group of the drugs, and the hemoglobin A1C is still above the target, then we have to go for the other agents. So looking at the point is that most of our patients require multiple drugs. Here it's very clear that even our diabetic drugs, usually most of the patients will be receiving 2 to 3 drugs. For example, patient receives insulin secretagogue, patient receives insulin sensitizer should be given twice a day or thrice a day. Likewise, insulin secretagogue can be given once a day or twice a day or thrice a day. So almost you are talking about only for diabetes control around 3 or 4 tablets in a day. And also we are talking about adding other drugs, for example, other insulin sensitizer, or you are talking about adding an SGLT inhibitors. So the number of drugs patient will receiving will be somewhere. Sometimes you calculate, especially when I'm working in a government hospital, when I give individual drugs separately, almost the patient will be receiving around 10 tablets in a day for only diabetes. Leave about the hypertension, leave about the lipid control, leave about our other antiplatelet agents. So forget about these things. Only for control of glucose levels, we are talking about patient having 6 to 10 tablets in a day. So coming from the reduction of hemoglobin A1C is so better, and it was shown that especially in UKPDS, you can see that if there is 1% reduction in hemoglobin A1C, as simple as 1% reduction, even as low as 1% reduction, can reduce the risk of deaths from diabetes by 21%, myocardial infarction by 14%, microvascular complications by 37%, and peripheral vascular disorders by 43%. So this is how a simple single-digit reduction in hemoglobin A1C would reduce the amount of complications very nicely. This is a beautiful UKPD study. There you can see here the graphical representation with reducing levels of hemoglobin A1C. You can see the complications will come down drastically. So this is the average glucose levels, and this is the hemoglobin A1C. You can see with the reduction in the glucose levels, you can see that the complications are coming down drastically. So looking at the challenges we face when you are treating the patients with diabetes mellitus. So we are looking at the parameters of carbohydrate metabolism and additional factors in relation to type 2 diabetes mellitus progression. So when you are looking at the parameters of carbohydrate metabolism, we have a stage in the pre-diabetes, then we have a diabetic stage, where here you can see with reduction in the beta cell function, which goes on smoothly down and down, there is increase in the glucose levels. And there is need for multiple add-on pharmacological interventions. And you remember when there is a need for multiple add-on pharmacological interventions, then the patient will have more chances of hypoglycemia. So the additional factors we have to look at when the patient is getting more and more drugs and more appetite, more weight gain, then of course, the most important thing is the cardiovascular risk goes up. And of course, there is increase in the diabetic complications also. So the paradigm and several challenges in the treatment of type 2 diabetes is, one is to control the glucose levels. Then we are looking at the prevention of hypoglycemia and preserving the beta cell function without increasing the weight and preventing the cardiovascular complications and the other microvascular complications. So this is how we treat our patients, try to treat our patients with type 2 diabetes mellitus, and they all need so many drugs. So looking at the ideal intervention, you can see first we have to improve the beta cell function, at the same time reduce the glucose levels. So this is the loop which is very much important. This will help in the reduction of hypoglycemia, and naturally this requires multiple add-on therapies. And that eventually results in the not of much weight gain, and of course there is a decrease in the cardiovascular risk and the complications. That's what we are looking at. So coming to the drugs, before talking about the metformin, once we have to remember that most of our patients, even you remember that days old, our treatment of tuberculosis, usually a patient requires 5 to 8 tablets in a day, and the compliance was so low that most of the times, most of the patients by the end of 1 month of treatment, people used to take only half the tablets. So there is a drastic thing which has made us very difficult to treat our patients and reduce compliance and the emergence of resistant tuberculous bacilli. So with the introduction of combination of the fixed dose combination of these drugs, only 2 tablets in a day would make my day in those days of my practice, when I gave most of my patients the fixed dose combination, and around 90% of the patients are compliant. So that's how the fixed dose combination resulted. And we have to have a method by which we have to have a combination of the drugs which have a complementary actions, and of course, they should not interfere with action of one another or the absorption. So coming to the metformin, which is the first line agent, of course, is a 50-year-old molecule, my favorite. And I always say that we Indians gave this molecule to the whole of the world, though the molecule was invented there. They never used molecule to their full capacity. Ours is the only country where we are using this molecule for the last 40 years without any doubt over this molecule. And the current guidelines from both ADA, EST and all societies say that you initiate all the patients on metformin because it is the first line of the drug, and a combination also should combine metformin with other drugs. So if you look at the metformin, it primarily acts on the liver, and naturally it inhibits the hepatic glucose production. When hepatic glucose production comes down, the glucose levels get controlled. So when you treat the patients with metformin, always metformin's side effect is gastrointestinal side effects. So it's always better to start with the low dose and gradually increase the dose. And there's a linear dose effect relationship. So the most effective dose in reducing the hemoglobin A1C is 2000 milligrams, whereas the fasting glucose is 1500 milligrams. So this is the dose, and naturally minimum you have to give the dose drug 2 or 3 times. So in a meta-analysis, where the research is from Medline, Embase and the Cochrane library, it was found that metformin monotherapy reduced hemoglobin A1C by 1.12%. This is almost equivalent to most of the drugs. And as I mentioned, the fixed dose combinations are the choice of the day. And because they have to have a complementary mechanism of action, the low dose combination therapy compared to high dose monotherapy. So this is what is there. Previously we used to reach the highest dose of single drug, then add the other drug. But now we are talking about adding low dose of 2 drugs, then reaching a high dose of monotherapy, which might exhibit less of the effects. And whereas they can achieve similar or better glycemic control. So the advantages of fixed dose combinations are they reduce the number of the tablets, the frequency of administration, the flexibility of dosage administration, and minimize the treatment complexity, thereby improving the patient adherence. So the most important, especially you are talking about geriatric population more than 70 years, the number of tablets are so much, always there is a chance that they can forget, or they have a chance that they can take an extra drug also. So here also it is very much useful for the patients. So there is a systemic review where it was shown that the fixed drug combination therapy may have better adherence, improved satisfaction, and lower direct medical costs. This is what, when the two drugs are combined, we know that most of the times the price would be less than you combine both the drugs. So if you combine metformin plus DPO4 inhibitors, you can see that the complementary actions. You can look at the pancreatic beta cell, pancreatic alpha cell. We are looking at the increase in the glucose-dependent insulin secretion and suppress the glucagon secretion. DPO4 inhibitors comes into play, whereas naturally our metformin reduces the hepatic glucose production, and DPO4 inhibitors also does it by increasing the insulin. And looking at the peripheral insulin resistance, metformin does it. When it comes to the safety and tolerability, lower risk of hypoglycemia is seen with both metformin as well as the DPO inhibitors. And of course, weight gain, you are looking at weight gain is lowest with the metformin and DPO inhibitors. So with these, both the actions are complementary in almost all, looking at the all pathogenic mechanisms producing the type 2 diabetes mellitus. So coming to the DPO inhibitors, the advantage being they can be orally administered when compared to other drugs which has to be given parenterally, and they improve the glucose tolerance and increase insulin release, and they're weight neutral. You can say some patients may have weight loss, but weight neutral most of the times, and the risk of hypoglycemia is very low. But the disadvantage is being sometimes, because we are inhibiting the most of the DP4 enzymes, though they are specific to DP4, but sometimes they may inhibit other DPP enzymes also. So the target may lead to unwanted effects of immune function, especially patients may have more of nasopharyngitis, some people may have pedal edema, some people may have headache is also reported, and of course, you know that DP4 acts over the pancreas, and there is a doubtful chances of pancreatitis, and arthralgia is also reported because of immune dysfunction. So these are some of the side effects, proposed side effects of DP4 inhibitors, but I find gastric irritation is the maximum. So looking at the DP4 inhibitors, we have Linagliptin, we have Sitagliptin, we have Veltagliptin, and we have Saxagliptin. So when compared that the hemoglobin A1C lowering the efficacy of these drugs, and it seems they're almost comparable. Not much of difference between all these drugs. When they used monotherapy or add-on therapy, then there is no much of difference. They're comparable. But you look at the bioavailability, of linagliptin is lowest, 30% when compared to sitagliptin, which is 87%, vildagliptin 85%, and saxagliptin 50%. But still, they have a comparable hemoglobin A1C reduction as far as treatment of type 2 diabetes is concerned. So the linagliptin was efficacious, safe, and well tolerated in Asian patients with type 2 diabetes mellitus and various degrees of renal impairment. So you can see not only so most of our patients may be having various degrees of renal impairment. Here they can be used without any adverse effects of like hypoglycemia, fluid retention, weight gain, and deterioration of renal functions. So you can look at linagliptin, which is very much efficacious, safe, though it has and can be given in almost all the degrees of renal impairment. And it was also shown that it an additional albuminuria lowering effect. So this is how we are looking at, and these albumin lowering effect is independent of alterations in the plasma glucose and blood pressure. How these drugs help? See, as far as incretin mimetics like GLP-1 analogs as well as DPO inhibitors have similar anti-diabetic efficacy, slight difference may be there, and whereas safety is concerned, tolerability is concerned, they score over the GLP-1 analogs. So when you combine them, they have complementary actions. Linagliptin inhibits the DPO enzyme, thus prolonging the half-life of our in the intestine secreted incretins. GLP-1 and gastric inhibitor polypeptide thus improves the insulin secretion, whereas metformin improves the insulin sensitivity, And the glucose lowering effect can be seen in the fasting state because it inhibits the overnight gluconeogenesis. And of course, metformin is also shown to have a GLP-1 production in obese patients, both non-diabetic as well as type 2 diabetic patients. So when you combine, this is one of the studies where it was shown that a 7-day crossover study has shown that the equivalent exposure and similar glucose inhibition with linagliptin, whether used on 2.5 milligrams twice daily or a single dose. And when they looked at the bioequivalence of these stents, 3 separate prospective randomized open label studies, they all showed that the single pill combinations of linagliptin plus metformin are bioequivalent to the individual tablets. So whether the linagliptin plus metformin are given to a twice a day or single day, the bioequivalence is same. And you can look at whether the food interfaces with the absorption of these drugs and changes of pharmacokinetics. It was another study showed that food does not have a clinically relevant effect on the administration of linagliptin and metformin single pill combinations. So the rationale is that they have a complementary actions, and metformin reduces the hepatic glucose output and improves insulin sensitivity and level of the muscle, whereas linagliptin increases GLP-1 levels and thereby stimulates the insulin secretion and inhibits the glucagon secretion. So this is how the synergy goes on. So this is how metformin reduces the gluconeogenesis and reduces the hyperglycemia, and linagliptin depot inhibition with increase in the insulin levels and suppression of glucagon. Of course, this is glucose dependent, so there is chance of hyperglycemia is less. So there is control of both fasting as well as postprandial glucose levels. So when you look at the combination in comparison with placebo, this is a beautiful study where it was shown that in a 24-week randomized placebo-controlled study, where it was shown that the hemoglobin A1C is reduced by 0.64%, fasting 1.2 millimoles, and postprandial 3.7 millimoles per liter. And whereas when you look at the body weight, there is not much of increase, there is no change. That's what we can look at. This is a study where you can show at the various doses of monotherapy, linagliptin, metformin BD, metformin 1000 milligrams BD, a combination. Then you can see the reduction of changes in the hemoglobin A1C from the baseline is almost 17%. And this is an open label study where it's almost 3.7. So you can see, this is 1.7% and 3.7%. So this is an article where it showed, published in Diabetes, Obesity and Metabolism, the initial combination of linagliptin and metformin compared with linagliptin monotherapy in patients with newly diagnosed type 2 diabetes and marked hyperglycemia. This is in this randomized control and actively controlled trial, it was shown that linagliptin in initial combination metformin in patients with type 2 diabetes and marked hyperglycemia, you can see that there is a significant improvements in glycemic control with low incidence of hypoglycemia, weight gain, and other side effects. So this is what it was shown, and this is another study which is published in the Diabetes Therapeutics. You can see that this is from Yaguanshi group, where they showed that early combination therapy with linagliptin, where they have taken 1,000 odd patients, treatment have more than half had diabetes for less than 1 year, that is early patients. So you can see that the baseline hemoglobin A1C is approximately 8.7%. And here the controlled hemoglobin A1C percent 6.5%, you are looking at without hyperglycemia. So you can see that most of the patients, they achieved a hemoglobin A1C of less than 6.5%, having this beautiful response. So early combination treatment with linagliptin and metformin can increase the chances of achieving tight glycemic control, that is less than 6.5%, without increased risk of hypoglycemia and weight gain. So the place as far as species are concerned, single pill combination concerned, is that it provides a reduced pill burden, improved adherence. Better adherence often results in the better efficacy, and of course, it is cost effective because a combination, usually the cost of the drug by the pharmaceutical companies would be less. So with this, we can safely say that the goals of hyperglycemia management in our type 2 diabetes are to reduce hemoglobin A1C and to minimize the diabetic complications, and of course to avoid weight gain and hypoglycemia. The depot inhibitors have a complementary mechanism of action with metformin, and the combination will provide better glycemic control because with low risk of hypoglycemia and no additional weight gain. By addressing the core pathophysiological mechanisms of type 2 diabetes mellitus, the addition of DP4 inhibitor to metformin delivers comprehensive therapeutic advantages. With this, I thank you all, and I thank Lupin for giving me this opportunity to interact with you. Thank you very much.